Hi, my name is Mao, and today I'll be doing a mini lecture covering Parkinson's disease. A quick overview before we dive deeper. Parkinson's disease is a common progressive neurodegenerative disorder that targets the basal ganglia. It primarily affects movement but also progressively affects non-motor domains. Motor disability increases the risk of falls, hospitalization, and the loss of independence. Non-motor problems such as sleep disturbance, constipation, mood changes, and cognitive changes often limit quality of life just as much as the motor symptoms. The good news is that early recognition, structured exercise, targeted therapy, and optimized medication can meaningfully improve daily function. The most consistent finding in Parkinson's is the loss of dopamine-producing neurons in the substantia nigra. It's important to note that clinical signs often do not appear until a substantial loss of these dopamine-producing neurons. Somewhere around 60 to 80% are lost before we actually see symptoms appear. There's no true known cause of Parkinson's. However, some risk factors include genetic mutations, increasing age, environmental factors, and oxidative stress. Individuals the most at risk include men over the age of 60 and those with a family history of Parkinson's. We can actually see evidence of Parkinson's in autopsies and with new neuromelanin sensitive MRI techniques by looking at the pigmentation in the substantia nigra. A byproduct of dopamine metabolism called neuromelanin can be seen in healthy individuals. Neuromelanin is thought to protect against harmful toxins, and when dopamine producing neurons decrease, so do neuromelanin. So protection decreases and ultimately increases the risk of Parkinson's development. This picture on the right is a really good visual that shows the pigmentation difference between a healthy individual, which is seen up top. We can see the pigmentation in the substantia nigra, compared to one with Parkinson's disease down here in the bottom. We see it looks pale and almost smooth in texture. You may be asking why this dopamine loss is so detrimental. Well, dopamine is a crucial neurotransmitter that both excites and inhibits the striatum through the nigrostriatal pathway. Dysfunctions of this pathway affect both involuntary and voluntary functions. Involuntary dysfunction can be referred to as positive signs, which, if it helps you think about it, think of positive signs as a positive presentation of involuntary unwanted actions while at rest, such as a pill rolling tremor as seen in the video over here on the left. On the other hand, voluntary dysfunctions can be referred to as negative signs, which you can think of it as a negative ability to perform wanted actions, such as a failure to initiate walking. So how do clinicians test and diagnose Parkinson's? Well, there's no definitive test for Parkinson's. However, you can assess 4 key motor symptoms for any deficits. And you want to start observing the patient's behavior as early in the visit as possible for any signs of bradykinesia, rigidity, resting tremor, and gait and balance issues. Equally, just as important is getting a subjective feedback from the patient and their family for complaints of gradual onset of slowness in daily tasks, movement execution faults, any noticeable decrease in facial expression, any noticeable cognitive decline, and softer speech. While assessing the patient, it's also important to be aware of 2 groups of disorders that affect motor function similar to Parkinson's disease. The first group being atypical Parkinson's, which just refers to a collective of primary neurodegenerative diseases, which that term primary neurodegenerative diseases just means that the cause of the disorder is either idiopathic or genetic. Approximately 25% of people initially diagnosed with regular Parkinson's later turn out to have a form of atypical Parkinsonian syndrome. The most prevalent diseases in this atypical group include progressive supranuclear palsy, dementia with Lewy bodies, multiple system atrophy, and corticobasal degeneration. Typical differentiating symptoms include postural instability, poor response to levodopa, early autonomic dysfunction, significant early cognitive changes, and abnormal eye movements. The other group is known as secondary Parkinsonisms, which just means that the cause is known to be from a toxic, infectious, or traumatic source. Toxic onset can be caused by side effects from prescribed drugs that treat psychosis, digestive problems, or drugs that block the central nervous system dopamine receptors. Traumatic and infectious onset can be seen through lesions of the lentiform nucleus and chronic traumatic encephalopathy, also known as CTE, which is seen extensively in contact sport athletes. Some signs that could point towards secondary Parkinsonisms, other than the similar Parkinson symptoms, include bilateral rapid onset and rapid progression of symptoms, as well as involuntary movements of the face and mouth. Unfortunately, there's no cure for Parkinson's at the moment. However, there are many treatment options available to help manage symptoms and extend the quality of life. The most common drug prescribed being a combination of levodopa and carbidopa, which works by replacing dopamine with L-dopa to alleviate movement symptoms. While levodopa is very effective for motor symptoms, as the disease progresses, many people develop motor fluctuations and build a tolerance, so the effectiveness slowly decreases over the years. Levodopa can contribute to some possible side effects, including hallucinations, delusions, psychosis, dyskinesia, and impaired impulse control that causes hypersexuality, eating disorders, and gambling due to the increase in dopamine. Things like occupational and physical therapy can and should be implemented as soon as possible to help prolong functional independence and mobility. As the disease progresses, speech-language pathology may also be needed to help with communication and swallowing. A more aggressive treatment option after drug intake no longer works is the implantation of deep brain stimulation to reduce motor symptoms. This is done by the implantation of an open-loop electrode in select brain regions that delivers continuous electrical stimulation. This form of deep brain stimulation does lack the adaptability to symptom fluctuations throughout the day and can lead to over or under stimulation during on and off phases of stimulations, since stimulation is continuous. However, early in 2025, the FDA approved the first fully adaptive closed-loop deep brain stimulation system for Parkinson's in the US. This device can record brain activity and automatically adjust stimulation in real time to better match the patient's fluctuations. Spinal stimulation is still an emerging field and holds a lot of questions and debates on its effectiveness on different populations. The literature surrounding spinal cord stimulation, specifically transcutaneous spinal cord stimulation, is conflicting and lacking research. Two 2024 literature reviews over the effectiveness of spinal cord stimulation in Parkinson's-related gait impairments concluded that current data does not support its clinical use. However, it did find some usefulness in improving Parkinson's-related chronic pain. Most studies were small and uncontrolled, and they highlighted the risk of placebo and blinding effects and called for rigorous sham-controlled trials before clinical adoption is met. On a more positive note, a randomized, double-blinded trial testing dual-site, non-invasive transcranial magnetic stimulation over the leg motor cortex paired with a simultaneous transcutaneous spinal cord stimulation, so just non-invasive on the skin, at the lumbar level in people with levodopa unresponsiveness to freezing of gait. They found improvements in freezing of gait and walking measures at day 1 and 1 month compared with the sham group. While these results were short-term, but they're very encouraging for the theory of spinal cord stimulation and its effectiveness against fog, or freezing of gait. Lastly, a 2021 review in spinal cord injuries showed that non-invasive transcutaneous spinal cord stimulation can activate spinal locomotor networks and change motor output. While it's not directly supporting evidence of Parkinson's disease, it shows evidence of the biological plausibility that could translate to the Parkinson's population. Ultimately, transcutaneous spinal cord stimulation and Parkinson's-related gait dysfunction still remains investigational, but very promising, and further research is needed to advance this therapeutic theory. All right, little quiz time. I prepared 4 short multiple choice questions. Question 1, which medicine is most effective for motor symptoms in Parkinson's disease? Option A, Botox with baclofen. B, levodopa and carbidopa, C, penicillin with an anti-inflammatory, D, Adderall and baclofen. Correct answer is B, levodopa with carbidopa. Question number 2. Which finding is most typical of Parkinson's disease on examination? A, loss of strength in all muscle, B, resting pill rolling tremor, C, complete loss of limb sensation, or D, double vision with loss of smell. Correct answer is B, a resting pill rolling tremor. Question number 3. Which therapy has strong evidence for the treatment of motor complication when pills are not enough? A, deep brain stimulation with basal ganglia target, B, an electromyogram with nerve conduction study, C, puppy yoga, or D, FES and IFC stimulation on the temples. Correct answer is A, deep brain stimulation with basal ganglia target. Last question. Which statement best describes exercise and therapy in Parkinson's disease? A, exercise is unsafe and should be avoided. B, exercise should be limited to 1 time per week for no more than 30 minutes. C, therapy is only helpful in the beginning stages. Or D, structured exercise and therapy can improve walking, balance, and daily function. Correct answer is D. Structured exercise and therapy can improve walking, balance, and daily function. Well, that concludes my mini lecture. I hope you enjoyed and learned something new or interesting, and thank you for watching.